Good morning, and Colonel Williams, thank you for that kind introduction, and certainly it's my delight and my honor to be here. I think this is such a tremendous event and activity to teach us all about where we stand in this very important disease state, prostate cancer. So I congratulate all of you as well, because I think that your being here is very important to want to understand the issues surrounding this topic even better, to inform ourselves really about what's going on, to empower ourselves to make the best decisions. And I always congratulate my patients if they come in and see me, wanting to be as informed as possible. Those are my best patients, because I think they're making the very best decisions in an informed way. And so I'm very appreciative of that. So I appreciate your being here, and I'm glad to share with you this topic area. I've been at Johns Hopkins since medical school about 35 years ago. So I've been kind of a bad run, I guess. I'm a urologist, I'm a surgeon scientist, I run a research laboratory, make contributions in the area of the science of the lower urinary tract, the bladder, the urinary outlet, and the genital area. Did some original science behind Viagra about 25 years ago that led to the science of that field. So I've had very much a significant vested interest in this area. I'm a prostate cancer surgeon, done about 3,000 of these surgeries, trained under Dr. Walsh. And my interest really surrounds not only just performing the best surgery we can for our patients, but really keying in on some of the outcomes and how we can do our best to maintain and preserve the best outcomes for our patients. In terms of these issues, urinary control and sexual function, again, the elephants in the room, as people heard, which our topic areas, of course, that many patients recognize are the reasons, the taboos that are difficult to discuss, but also the issues that sometimes lead them not to want to pursue treatment. We all know that, right? Many basically say, I don't want to pursue any kind of prostate cancer treatment because I'm going to lose my erections. But of course, we know that the ultimate form of erectile dysfunction is death, as one patient told me. And so I always try to teach them that we can address these issues after we manage the problem, but we certainly want you to be around for yourself, for your family, and certainly making the best decision that we can as professionals in the field to determine who needs to be treated is key. As we just heard from that wonderful talk by Dr. Who, many patients should be in active surveillance programs, so we should not overtreat. But I think we should all be informed, get evaluated, and make the best decision going forward. So my topic here is really to get into the management of urinary and sexual dysfunctions. I'm going to try and bring to you kind of the current concepts in the field. The American Urologic Association recently just published, just this past month actually, the AUA guidelines on erectile dysfunction management, of which I was the guideline co-chair. That was quite a production over a few years. So I'm going to try and bring you some of those concepts and how that fits with what we're talking about in the area in the arena here of prostate cancer management as well. Know that I think this could be somewhat interactive, and to the extent that if you have questions, even in the middle of the conversation, even though I try to work in some time toward the end, I'm glad to stop. So please know that if there's something that needs clarity or you just want to say, bring out a question, I'm perfectly okay with that. Okay, so I want to tell you that from the outset, because hopefully that will make sure with that exchange we're informing us all and teaching us all, teach me something about our discussion today. This is just a disclosure slide. As I mentioned, I run a research laboratory. I have a lot of interactions with industry, with grants and support from my fellows and residents. I write a lot of grants. It takes a lot of effort to be an academic urologist, but I'm involved in a lot of these sorts of things. So, management objectives here surrounding these topic areas is that we do want to preserve the best bodily function in all patients. Again, as I prefaced, this is where we run into challenges with managing prostate cancer, preserving one's urinary function, their sexual function, just their body image even, and just being able to have a functional day and all of the psychosocial ramifications surrounding that in terms of preserving health and wholeness, I think is the goal here surrounding what we do. I'm going to divide this talk initially talking about urinary control issues, perhaps the first 15 minutes, and then go into sexual function for another 15 or 20 minutes, and then certainly see where that goes with any other discussion points. So let's start with managing urinary dysfunction. The outline of the talk here, educationally, is just to provide some basic information here about definition, pathophysiology, and disease states surrounding urinary control problems in the setting of prior prostate cancer management. Patient evaluation. What kind of evaluation steps do we do? Again, I know this is a diverse audience. For some here who are already clinicians and know this may be a bit overlap, but for those who are not, what's important to us is we try to understand the presentation of urinary incontinence. So I'm going to try and share a little bit of that background with those who are less aware. And then where are we with treatment? What are our options, particularly on the surgical side, at least with urinary control management, although there's a great deal of importance on conservative management as well. So I'll touch on that. So what about some of the background information? Background story, epidemiology, is Dr. Who made that point. What is the incidence of urinary incontinence? That is the involuntary loss of urine that occurs. And you can see this can, in the setting of prostate cancer surgery, where we actually see this a little bit more commonly than with radiation techniques. You can see there's a wide range of reports. Certainly, it's not trivial and insignificant. It used to be, and I've been counseling patients of mine for 30 years with radical prostatectomy surgeries. We used to conceive that, yes, there's a 50-50 chance you'll be in diapers the rest of your life. Well, we certainly have improved upon that with better surgical technique over the years. And we understand that the mechanisms or pathophysiology likely has to do with sphincter weakness, the urinary outlet that can be traumatized based on the fact that the prostate sits right in the sphincter mechanism. Although bladder dysfunction also can be a contributing factor, and we recognize that. It's really kind of, at least for basic concepts for the group here, is it a bladder dysfunction problem? Is it a urinary outlet or sphincter mechanism that's the problem? Those are kind of the two main issues to resolve. Now we know about the continence recovery after surgery. The natural history is somewhat different than what occurs with treating localized prostate cancer with radiation. But surgery, it's very common that you treat, and patients immediately afterwards, upon getting their catheters out, will sustain some degree of urinary control problems in the setting of having had surgery, but then they'll improve over time. Radiation is a little bit converse. You have radiation, things may change over time with regard to urinary frequency, urgency, even incontinence symptoms that may emerge over time because of radiation effects. But the natural history, much of the time with surgery, is that there may be some impact early, there may be a need for pads over the months. Patients can improve with regard to their continence. Now what about patient evaluation? I put on this slide basically all of the basic elements of the diagnostic evaluation. It begins with history. Understanding really the nature of the urinary problems, when does the incontinence occur? You can see it just going along the slide, you can read from it. Diaries that can help us understand what may provoke incontinence, what are the factors that bring it on, what may be some of the ameliorative factors that alleviate or lessen the degree of incontinence. Does it occur with exertion or non-exertion? That almost is the fundamental. When I talk to patients, I immediately try to get a handle really on that dichotomy. Exertion typically means that their sphincter is weak, and anything that increases intra-abdominal pressure overcomes the strength of their natural sphincter. And typically that refers to sphincter weakness if it's incontinence with exertion. If it's non-exertional, such as just laying in bed at night, watching the news and sitting in your lazy boy, and you're having a lot of leakage there, that generally is not a matter of increased intra-abdominal pressure. That's nothing typically going on with exertion, I don't think, at that stage. And if a person's having a lot of leakage under those settings, that probably relates to a bladder dysfunction problem. That really refers to the bladder having this uncontrolled leakage at times, and we hear about this. We see these ads out there, gotta go now, and this and that. Well, there is this phenomenon out there of bladder disturbances. We call it overactive bladder syndrome, and that can be an overlay for many men, even if they've had radical prostatectomies. But in general, if there's leakage with exertion, that refers to sphincter weakness. And how we kind of conceive of what is the nature of that man's incontinence just by their clinical history. Pad usage is important. I'm going to allude to this further on in the talk. This is important because we use this almost as a surrogate for the severity of the problem. Everybody conceives of their incontinence differently. I've had patients come in and say, this is the most disastrous thing. How many pads you wear? 1 pad. Okay. And I have other guys come in who are wearing 5 pads a day and their lives are wonderful. Maybe and that shows that people have different concepts of the severity of the problem. And there is kind of a matter here of how we all perceive of the nature of the problem for each of us. But you see, that's kind of widely different, and each of us might say, well, what's wrong with kind of 1 pad a day compared to 5 pad a day? Well, that shows you that, yes, we think of it objectively, at least as a more severe problem for that patient who's wearing 5 pads a day, at least in terms of life inconvenience and so forth. But certainly we do understand how much it impacts patients too. They can vary. We have quality of life questionnaires in our field. There are various ones out there. I try to keep it simple in my clinic, with the exception of clinical studies we're doing. We don't want to burden patients too much, but there are various questionnaires that are available. Examination is important, just to review the neurological status of the patient. We evaluate various aspects of their motor function, their ambulation, even local evaluation in terms of rectal tone and things like that. That may give us a sense of whether there's been any kind of neurological impairment that relates to why they're struggling with their incontinence. On the right side, there are a little more complex aspects of the workup. We may do an evaluation in terms of their urinalysis, at least. Of course, that's common in the urologic clinic, get a urine sample from everybody, right? But the lab test may help us understand are there other associated medical conditions or comorbidities, other phenomena of diabetes and other aging, stroke, and Parkinson's and other things that may fit with that. But largely working with our internist colleagues that may help us understand the health status of the patient. Urinalysis, if there's blood in the urine, infection, we're going to want to work that up a little bit more in terms of other factors that may contribute to that presentation. Post-void residual, we always evaluate for that. That's simply done with a scan in the clinic. We have a patient go void, come back from the bathroom, lie down, put a little bladder probe and kind of an ultrasound technique to evaluate are they retaining urine. That's important because some patients actually have a paradoxical presentation. They're voiding, maybe having some frequency leaking, but maybe they're retaining urine too. And there's sometimes that phenomena here of really what is the presentation about in terms of leakage that may be solely a matter of sphincter weakness, even if they're telling us it's an exertional problem. But they may still actually be kind of like the cup under the faucet, just emptying a little at a time. And no wonder the cup's overflowing here and there, so-called overflowing conditions that can confound the assessment. Urodynamic evaluation, fancy term, urodynamics. What that is an evaluation we'll do in the clinic where we are attempting to objectively assess that person's lower urinary tract function. And we may do an evaluation. We put probes through the urethra and the rectal area. These little probes can measure pressures. We can fill through the probe through the urethra, the pressures in the bladder, fill through that catheter to get a sense of when do you have sensations of filling, when do you feel full, when does leakage occur. We can actually get objective measures of that person's bladder capacity and the volume and pressures when they leak and all these kinds of things. I don't want to make it more complex than that, but sometimes that can be helpful to assess really objectively what's going on with that person's lower urinary tract function. And we try to bring that in to assess in combination with their clinical presentation. You can see from the slide I say its role may be dictated by the presentation, meaning that we may not feel that it's necessary to do this on every patient. Okay, and in fact, I tell you these days I almost randomly, not frequently do it on patients unless there's a more complex presentation or something's been, the patient's been through various other kinds of additional anti-incontinence surgeries and makes things a little more difficult to assess what the nature of the problem is. But on routine assessment, this may not be always required. Cystoscopy is a good evaluation. That's where we take an instrument called a cystoscope and look up through the urethra into the bladder and evaluate under direct vision as the urologist the urinary outlet, the sphincter mechanism, the bladder itself, rule out any other masses or foreign bodies or any other objective issues that have to do with the anatomy and structure of the urinary outlet area and bladder. And that becomes very useful many times when we think about the sling surgery which I'm gonna get to in a moment. You may have heard of that. The sling surgery, which really it does hinge on our understanding about how well that person's native sphincter seems to be functioning, because that sphincter looks like it's closing and at least coacting, as we use the term. That tells us at least it has a closure mechanism. It just needs to be bolstered a little bit. But if somebody really has a urinary outlet that's really not closing much at all, really does look very dysfunctional, and particularly if there's been scarring or any other radiation or scarring effects, contractures that needed to be opened up transurethral, that is through the penis, and try to cut those open. If that sphincter really looks dysfunctional, we are very concerned about that element of sphincter weakness that may be best handled by an artificial sphincter, not a sling. And I'll get to that a little bit more in a moment. What are the options for managing urinary incontinence, particularly sphincter weakness, okay, which is the predominant pattern we'll see in the post-prostatectomy setting? Medications top the list, and this, you can see the list here almost follows the least invasive to the most invasive, kind of in a cascade here on the slide. Medications certainly are the least invasive, in addition to just counseling and behavioral modification. But medications here have to do with the fact that we do have some sense of the pharmacology, that is the receptors and drug functions and that sort of thing, the chemistry of the urinary outlet. And we have various drugs we use that we think might increase the muscle tone of the sphincter if it's weak. And there's medications we have used in our urologic clinics, and they may have some minor efficacy, but they may have a better role in somebody who has just some minor degree of urinary incontinence associated with sphincter weakness. And so, but their strategies may actually be limited to those patients. Physical therapy is coaching patients about how to work and strengthen your sphincter. Have you heard about Kegel exercises? Okay, if someone familiar with those, where you actually clench and pull and tighten that sphincter muscle and try to, almost like a novelist exercise routine. Imagine that on one of these late night shows, telling people how to do all that on the TV. But basically, how you clench the muscle there, sustain that contraction, and really work on that. We coach guys a great deal of that early following radical prostatectomy. I think many urology clinics do that to try and see if the person can regain their sphincter control naturally. And so that's largely what that has to do. There's various other techniques surrounding that, biofeedback and various other kinds of elaborate testing in some of the physical therapy clinics. But basic concept, that's what it's all about. Injectable bulking agents, okay, what that has to do with is that we basically recognize that the urinary outlet, like a donut hole, can be made a little tighter if it doesn't really have at least some structural closure to it, and injections of substances right where the sphincter area is, if you can visualize what I'm saying, can bulk the area up a little bit and attempt to reduce the degree of leakage. And we've had various substances that we've used over the years. The challenge with this technique, just to let you know where we stand, I used to do a lot of these when a lot of these techniques came out back in the mid-1990s. They've fallen out of favor somewhat because they really don't seem to have durable effects. And they may help you for a little while, but they seem to fade, and we still are struggling to come up with substances, either natural or synthetic, that are safe, don't migrate in the body, cause ill effects, but also seem to have at least a durable way of staying where they need to be, and the body won't just kind of degrade it over time. And we look at there, that donut hole is kind of patulous. We inject substances and tighten it up, and then 6 months or a year later, it just kind of comes back. And so this is a kind of technique that may not be one that suits many men for the long term. And no need repeated treatments. What can we do that's really going to be effective and get them on their way? Male slings and artificial sphincters, I'm going to talk about those, so I'm going to put those aside for a moment. And then continent urinary diversion is the last option. What is that all about? Okay, what that's about is for those men who have very severe incontinence problems or other complications. A patient this past week I had to do urinary diversion on, who actually had some serious issues and had radiation with damage near the rectal area. And basically what that is the surgeons will open a person up, surgically create a diversion with a segment of bowel and connect it and separate where the urine comes to the bladder. The bladder may be dysfunctional, it may be damaged in a significant way, and we hook the ureters, the tubes that come down to the kidneys, to this segment of bowel and have that come right out to the abdomen and have kind of a little stoma there. and reconstitute the bowel so everything's back intact. But this little stone one with a collection device is how they'll go forward in life with a urinary bag on the abdomen. So you've heard about that kind of thing maybe sometimes. And so sometimes for very severe problems, we have to consider that sort of intervention. All right, so just some images. I guess with these kind of talks, it's always tricky. You don't want to be too graphic with some things for an audience. But here, this is just meant to show what it looks like with on the left side here, a single cuff artificial sphincter. On the right side, a dual cuff artificial sphincter. Essentially, what this is the device of artificial urinary sphincter devices. All right, how many in the audience have heard about these? Just some, but not everybody. Okay, so this is new to some then. All right, so this is a device that we've had for actually 3 or 4 decades now that have been improved upon. And these are for men who may have more severe incontinence, enough that they want to preserve the real integrity of how urine passes. Nothing as severe as undergoing a urinary diversion. But what it is it's a device that involves 3 components: a cuff that's put around the urethra. It's a cuff that's put around the urethra here, that you can see here. And surgically, we approach that much of the time with a person's legs up in stirrups, the lithotomy position. We surgically come in between the scrotal and anal area, identify the urethra, dissect that out, put this cuff around the urethra, which is almost like an inner tube of a tire, the size of a lifesaver. Okay, that's connected by tubing to a pump that's in the scrotum, and then this reservoir, or pressure regulating balloon as we call it, that's put up inside the abdomen. All this is a self-contained device, all connected by tubing, what this is then is solution is put inside the system, not to mix with the person's bodily solutions. And by manipulating the pump in the scrotum, fluid can be transferred between the cuff that at a baseline level, okay, the default level is this gently compressing the urethra so the man does not leak urine. And then when he feels that his bladder is full naturally, he goes to the bathroom under control and reaches down and just depresses the pump in the scrotum that you can feel through the scrotal skin. One momentary squeeze causes the fluid to leave the cuff, go back to the pressure regulating balloon briefly. The cuff release now allows the urethra to the urine pass. It passes over about 30 to 45 seconds, and then the system recalibrates within that period of time, where the pressure regulating balloon transfers fluid back to the cuff and it tightens things back up. And that's basically how a person has this sort of system work in their body. The battery is their fingers. It's just how well you squeeze it, and just a momentary squeeze is how you operate it, and then it goes back to baseline after the urine passes. So that's what an artificial sphincter device is. What are some basic outcomes? Again, I don't want to throw in too many tough statistics and complex stuff here for this talk, but you can see right from the slide that in general it has success rates, but it is a surgery here. And I always counsel patients to know that, in terms of the surgery, it's about a 1% infection rate. That's the thing that we dread the most with artificial devices, although we've actually perfected this well enough to where we give antibiotics. The parts of the device are pre-coated with antibiotics, done in a very sterile way, so the infection rate is very, very low. Technically, it's demanding on somebody who really is a surgeon that does these surgeries regularly, because there is some complexity in putting these in. But they are generally very successful, and they do have good longevity. However, they're mechanical devices, and so it's not going to be quite like a natural sphincter mechanism. Over time, they may require revisions. We know at 10 years, probably about 30 to 40% of them may need to be revised. But it's not something we're doing like every other year on somebody. Really they should have a good duration of being dry. So we know they work well. We know that if you have any significant exertional activity, you may overcome with abdominal pressure. So either going out playing golf all day, you may still need to wear a light pad because you may overcome the cuff closure pressure. But in general, these do have great impact, and it makes a difference for our patients. Success factors have to do with selecting patients well, counseling them. You hear some of the issues that I brought up here for discussion. Those who have very unstable bladders, those may still struggle with these devices because they have these agitated, unstable bladders that I kind of referred to earlier. That may still be a persistent problem in terms of urgency, frequency, and some of these symptoms that are not going to be alleviated by addressing the urinary outlet alone. Now, by contrast, there are the male slings. Now, how many have heard about slings here in the audience? All right, how many have not heard about slings? All right, how many are asleep? Okay, no, just kidding. Okay. All right, so my telling you about this is going to be informative then. So slings are devices that we've had around for decades. There have been various versions of this. I've given talks to mainly urology audiences where I'll go through the history of slings from years ago and various kinds of techniques of doing this and that. But for our conversation today, this is just where we stand in the field. This refers to, as slings would suggest to you, something that sounds like it's a bit of a harness, a bit of a kind of a device that looks like a hammock, and actually kind of sort of is. You know, we actually surgically, again with the patient's legs in the area, make an incision between the scrotal and anal area, go right in that area, find where the urinary outlet is just beyond their native sphincter, and locate a place where we suspend this sling in such a way that it's elevating and repositioning is the better word we use. In guys whose sphincters are really not that functional. Okay, so it really comes down to guys who are wearing 1 or 2 pads a day and so forth. I'll get to that in a moment. But you can just see just from the diagram basically what I'm talking about in terms of how these slings are done. They're actually done very smoothly. These slings are little synthetic kind of fibers. You see these things, and there are different companies that have their kinds of devices. Here are just a sling that we put in and actually just come through one area deep in the pelvis. There's these quadratic slings, fancy terms for various other ways we create suspension with these slings. Like again, like the hammock between 2 trees, you got to suspend it somewhere. And so there's different versions of this, but essentially that's the concept. Success rates tend to be good in a properly selected patient. Okay, and you know, I'll let you read from the slide. The slings themselves surgeries are done in about an hour or so in the operating room. The success rates are generally very well. They're tolerated. It's not a big operation in general. Infections are low. There may be some nerve pains in the area depending on how we have to transfer these, using little transfer needles and so forth. Usually that's temporary. Some if they're too tight, can have some retention problems. But again, I think if it's done well, those rates are fairly low. And so it addresses the problem for many men. Now, the interesting thing is how successful is it in deciding between different patients. So this slide, I think, is very useful. Take a moment to look at it, because this is how we make decisions about incontinence, by and large. If a man has enough incontinence and says, yes, I'm wearing pads, and I can't get by just, now it's 6 months or a year later following radical prostatectomy, the natural history is such that men may not by that stage have recovered their continence. By that time, they're largely plateauing with regard to their best improvement, and we may have to consider surgical intervention. Generally, we don't try to intervene with surgery too soon after surgical intervention for incontinence, too soon after a radical prostatectomy, because in the first 3 to 6 months, a man may still, with Kegels and time, get his sphincter control back. So in general, we're delaying at least about a year or so. And then that man's coming in saying, yeah, I'm still wearing 5 pads a day. Well, we may have to think about the artificial sphincter. If he says I'm wearing 1 or 2 pads a day, you may have to think about the sling. And you can see some of the criteria and things to think about here right on the slide. But in general, just for your mental framework, that's how we typically think of how we make these decisions. Now, each man may have to help us decide what he thinks is right for him. Some men say, I don't want a device that I have to really manipulate. And I'll accept, even if I'm wearing 3 or 4 pads a day, a sling whereby I may still need to wear a pad or 2, where I just naturally would, because a sling surgery, you don't have to operate anything. We just tighten things up with that sling, and then you're going about natural voiding. When you feel full, you empty. You go to the bathroom, you empty. You don't have to operate anything. It's just a way of trying to revise your urinary outlet to make it a little tighter. But everything else about voiding is what it is. Okay, nothing that we're asking you to do anything more than that. The artificial sphincter, you have to be aware and knowledgeable about how to operate that little pump, even though it's just a momentary squeeze. Some men aren't too keen about that, and they'll accept saying, okay, as long as you can get me down to 1 pad a day, I'll live with that, and I just want to avoid normally. And then maybe a sling would be the option. But in general, the more severe incontinence, the man has had prior radiation, the man has had a lot of surgery in the area where the urinary outlet does not have at least a natural closure, like a shutter of a camera. That guy may not do that well with the sling, and I have to counsel him in advance, as we should responsibly do, to say, these are the true expectations of the surgery. If your natural sphincter has been radiated, you've had a lot of scar tissue there, if I do a sling surgery with you, you may be improved, but you still may need a pad or two. And if that man says, I still want a sling, then we understand what and hopefully he's understanding that's the decision that we're making about that. The expectations are well set. Now, have I had guys that put slings in and then come back later and put an artificial sphincter? Yes, I've done that. They say, I want a sling, see if it helps. And if I still have severe incontinence, maybe I'll think about an artificial sphincter at that point, yes. And I've done that. But in general, I try to work with each patient, understand their preferences, their objectives, understand their clinical profile, what seems to make sense, and try not to have them back and forth in the operating room. Let's try to make the best decision right from the start. But this gives you just a general sense of how we decide who gets what. So, with regard to incontinence, particularly in the post-prostatectomy setting, we know this is a reality that can still occur even in the modern era where we have improved upon our incontinence rates. Nowadays, I think long-term severe incontinence for most men undergoing radical prostatectomies, and where surgeons are very experienced, there are probably less than 3% of men who so I showed you that statistic early on, but I think it's probably in that arena, that kind of range of really wearing a significant amount of pads post-radical prostatectomy. It's still a major quality of life issue. Nobody wants to be wearing pads. That's a huge inconvenience. For some, that may be even more important than any sexual dysfunction. And I accept that, and I think that's very important. Keys for therapeutic success is to diagnose it accurately, select patients well, and you have a basic understanding of how we think about incontinence, okay, and how we would implement the right intervention, and make sure we're making the best decision where we can. All right, let's change briefly now to the topic of erectile dysfunction. Any questions thus far about incontinence? Any burning questions?
Quality of life questionnaires that you use routinely.
So the question is are there any quality of life questionnaires for urinary incontinence that I use routinely? And the answer is that routinely, I just use the International Prostate Symptom Score in our clinic, because that's a simple little Likert scale that can be filled out in a few minutes, and just that covers almost anything from bladder instability to lower urinary tract symptoms to incontinence, and we just get a general sense right out the gate for that. There are other tools out there, the EPIC tools and some of the others that I can refer you to look up. But again, I don't use those routinely because I think it's a little more burdensome to do. And you can see these are being maybe useful more for doing trials and things of that sort. Because we can quickly, you've heard the discussion, we can quickly get to the answer without burdening patients, at least for routine clinical practice. Other questions at the moment? Okay, let's go to the next topic then. All right, so as a matter of outline for this portion of the talk, we're going to talk about, again, some epidemiology, where we are with management, and really give you a sense of where we're going in the future in erectile dysfunction, exciting, perhaps, innovations in the future. So this just offers here some insight as to the challenge that we have had. Try to understand the phenomena of erectile dysfunction after treating prostate cancer. I was on the AUA panel 10 years ago, wrote up this article on how we actually understand the outcome of erectile dysfunction. And you can see the wide range of numbers here for complete erectile dysfunction, partial erectile function, intact erectile function, for radical prostatectomy, external beam radiation therapy, EBRT, and interstitial radiation therapy, the seeds or brachytherapy. And you're probably looking at it and say, man, these physicians don't even know how to know, they don't even know what they're talking about. These numbers are all over the place. How ridiculous is this? And I can tell you, this was a challenge for us to actually scour the literature, go back a few decades in time, and try to give really a meaningful report of the data. The data is all over the place because of confounding elements of not knowing what are the true definitions of the problem, not having proper evaluators who try to get the handle on really what the problem is. We're guilty as physicians we'll ask the patient, how's your erectile dysfunction after surgery? Because yes, I'm a great surgeon. Oh, I'm struggling a little bit. I occasionally get an erection, maybe 1 in 20 times. You're intact, no problem. You know, but is that fair? You know, and the literature abounds with these kinds of assessments that may not be completely precise about what the person's level of function. And maybe there are a lot of retrospective studies, a lot of recall biases with regard to reports. So you can see it's problematic all the way around. And I think, fortunately, in recent years, we're doing a better job of prospective studies, defining the problem well, and trying to get a handle on really what is the true rate of the problem. Historically, if you underwent this surgery, it's well known that almost every man would be impotent. One of my mentors, Dr. Walsh, certainly has, I think, helped bring the field forward with some innovations with surgery, the nerve sparing technique I'll talk about briefly, and that was in the mid-1980s that came about, and that has improved outcomes. So, you know, doing the surgery better, we're changing some of our rates, but we need to be honest with ourselves about how we really rate the problem, and that's been problematic in the past. At the same time, there are a host of variables that impact erectile function recovery. Some of these have to do with the medical care provider. Some of these have to do with the patient, okay? And the reason I make that point is because when I counsel patients, I want them to know that I can't be a miracle worker for everything that goes on. And some patients truly believe that. I think we put out there, you know, with everything we do with our ads, you know, service me now, upsize me, make things better in an instant. You know, all these kinds of messages are out there. But, you know, part of it is what is that person's otherwise health comorbidities? If they have other health problems, if they're not in the best fitness, if they're cigarette smokers, if their diabetes is not well controlled, all these are factors that, despite the best attempts we do as surgeons to do the surgery, these impact upon the blood vessel function, the nerve function in our bodies that have to do with sexual ability and urinary ability. No doubt, surgical trauma plays a role. If we don't do these surgeries well, we traumatize the nerves and blood vessels deeply in the pelvis that run to the base of the penis and regulate erection. No wonder, if we don't do these surgeries well, that some men will have trouble. There may be other factors here, psychosocial factors, okay, that interplay with regard to the severity of the problem. We know that erections is a mind-body experience. It's not always physical. There may be an overlay of emotional and psychological components to it, so we have to understand all these factors as well. And again, I just mentioned the health comorbidities from cardiovascular disease, and even just as men get older, their bodies, we all know that, we're not 25 anymore. We kind of hit that point, you know, things change. And it's interesting, you know, with some hilarious examples on the side here, that we exercise our dogs, not ourselves, I guess sometimes. We need to be better shape you know, with regard to our overall cardiovascular function. Erectile dysfunction largely is a penile vascular disease, okay? We use the word erectile dysfunction, all right? The consistent inability to attain and maintain an erection of sufficient quality for satisfactory sexual performance. Okay, that's a broad definition that we try to use to be clear about what the problem is. It's not libido issues, it's sexual interest and so forth. It's not just how aroused you may be, you know, mentally. It may not be just your overall sense of ejaculatory function. These are all other elements of sexual dysfunction. But we're talking about just the ability to get an erection, the penis being functional. So we have to be very precise, but that's confounded in a lot of assessments in the past because we just just combine all these and just jumble them all together and think we're talking about the same thing. But in terms of getting an erection, it requires your blood vessels in the penis to work. It requires the nerves that come to these blood vessels and regulate how the blood flow gets in the penile area. And really, so that the disease state is what it is. Erectile dysfunction itself is really a subjective complaint. Okay, erectile dysfunction is not a disease in itself. Urinary incontinence also is not a disease in itself. Okay, these actually are just subjective complaints. The underlying conditions is what we're talking about as to what erectile dysfunction is all about. And these are the various underlying kind of conditions right here. Okay, and recognizing that in many men, they have these concomitant issues, even in the face of doing a prostate cancer surgery or radiation. These may still be factors that can affect their best preserved erectile function. So what are the basic concepts for preserving function here? Well, the basic concepts are to minimize dysfunction, try to get a person in the best health status possible. When they undergo our treatments, do our very best. As surgeons, we need to do these surgeries almost neurotically, very well, to make sure that we do our best job to understand how the prostate's removed and less likely affect some of the surrounding structures. We've gotten better and better with that over time. In terms of managing the erectile dysfunction after treatment, manage ED, and I'm going to tell you what the options are here in a moment. Managing the ED, what are our current options? What works? And then for the future, we're thinking about here, what can we do to preserve erectile function and preserve function and maybe even improve function over time? And there's rehabilitation techniques. You may have heard about penile rehab. People heard about that? Sounds kind of, what's going on with that? Where you go and rehab your penis. Well, I'll tell you what we think about that in a moment. Ways of just intraoperatively protecting the nerves, protecting the blood vessels, what kind of techniques we have to offer in that regard. And then new ideas about maybe reconstituting some of the blood vessels and nerve structures and rebuilding aspects of the pelvis. You know, you may have heard me do this penile transplant a few months ago at Hopkins. I was the main urologic surgeon involved with that. That's a very big reconstitution technique, but at least for men who have prostate cancer surgeries, what can we do, at least for the common guy undergoing that may be coming about for the future? I'll tell you about that. All right, so this just tells you right on the slide, what do we have for managing erectile dysfunction? Now I can tell you, back when I started practice, when I finished training and so forth in the 1980s, basic management for ED was, Mr. Jones, we've got some yohimbine pills. I'm gonna write you for that. I mean, I wrote somebody that, man, it's like ingrained in my mind. 5.4 milligrams POTID, try that for a month. You know, I read that in my sleep. Because we didn't have much else to offer, okay? Take these pills, they're herbal supplements. It almost differentiated guys who had a real physical problem versus having kind of a psychological overlay. And if they didn't do well in a month or two, well, you want to get a penile implant? You know, that's what we got. Well, we needed to do better. We have. We actually understood the science of erections better. We developed drugs that really are based on the science of penile erection. Those are the PDE5 inhibitors. Okay, you heard about these. The main one is sildenafil, Viagra, but there's also others. Cialis, which is tadalafil. There's Stendra, Vanafil. There's also Levitra, which is vardenafil. So all of these drugs are based on the science of erections that we figured out in the late 80s, early 90s. We recognize the role of therapy. We also recognize the role of other therapies we brought along, which include these minimally invasive, non-surgical interventions such as vacuum erection devices, intraurethral suppositories. You may have heard of that, MUSE, medicated urethral system for erection. That came out around 1996. And what basically that is a medication that's dispensed in the urethra, like a big pen. You remove the pen, massage the penis, hope that some of it gets absorbed and gets through the urethra into the main erectile bodies of the penis and bring about an erection response. So that's a technique that's somewhat separate than the injections. The injections, using a diabetic needle and syringe, injecting medication in the side at the base of the penis to deliver medication to create erection. So these are pharmacologic techniques of delivering drugs that we know are like the oral medications, but they're more of a variety of those drugs we call vasoactive drugs, injected into the penis or delivered intraurethral to bring about a local pharmacologic effect based on the science of erections. So that's how we've been able to bring forward the field with these other options. The vacuum pump is an external cylinder brought over the penis. The story behind that, I think, was an ingenious patient who had his automobile or car garage and played with some auto parts, and the next thing you know, they would bring about a device to create a vacuum effect the penis, and actually build a business based on that. That's a true story. But basically, the schema I'm showing you here are treatments for the symptom of erectile dysfunction. They don't really correct the underlying problem, okay, the underlying vascular disease or the neurologic disease. And this is where we stand in the field today. That's why I always preach to my residents and others in the neurology talks is that we've not figured out the holy grail of erectile dysfunction yet. Because the treatments we have, largely right now, are just helping man just get the erection. we still have to figure out really how to do better still. Even though we know some of the science and have drugs that can take advantage of kind of the chemicals that have to do with erections, can we correct this problem? Can we solve the disease in the penis? Imagine in the future we'll have somebody come in, do a treatment, and they're better sustainably for some period of time. That's what we still need to do. But right now we have, at least according to the process of care model, first line, minimal pills and therapies. Second line, these kind of minimally intrusive local therapies that just help you bring about an erection effect. And the third line is the surgery. I'm going to talk about the surgery a little bit more. I think you see me kind of deferring on that for a moment. But the success rates of all of these are generally very good, except for the intraurethral suppository. That the truth about that is probably about 20% of men have really successful effects with that. Some of it just doesn't get absorbed well. And so it's kind of fallen off the wayside a little bit. But the pills can work in the appropriate man. Probably about 60 to 70% of men respond to the PDE5 inhibitors. The vacuum pumps, 90% of guys, if you put a device on there and create a vacuum effect, it can work. You know, constriction bands put on the base of the penis. You have that, so it works largely. The injection, we can find the right cocktail, almost like the gas pump. You know, you got regular, you got premium, you got high octane. We can mix drugs up and figure out what we can do to get something that'll work for somebody. And so that works 90 to 95% of the time for guys coming in. So we have these options, all non-surgical. They can work. The penile prosthesis, as you might imagine, is surgery. It's not non-surgical. Some men do opt for it. Okay, and you can see just from the diagram what it is. This is a device put inside the penis, much like the artificial sphincter is a device put inside the urinary tract area. It has components to it, the two cylinders in the main bodies of the penis, the pump that's in the scrotum, a reservoir that's up inside the abdomen. All of it is connected by tubing. The solution inside, again, is normal IV saline kind of solution, so it's safe. And really it's basically a matter of hydraulics, using the pump mechanism in the scrotum to transfer fluid from the reservoir to the cylinders to make the penis come up. So a pumping mechanism, again, the battery is right here. You gotta move your hand right. And of course, we're working in the field to develop new devices that may just automatically do this. That's going to be the future. But right now, guys can pump it up and the penis comes up, like the Nike sneakers. Pump yourself up. All right, then you're good to go. And everything about the penis is intact in terms of sensations, in terms of orgasmic ability, in terms of just being able to function. This is a device that provides a splint for the penis, provides rigidity, but everything else is intact. Everything's intact about the penis, and when you're done with sexual activity, you manipulate the pump to bring the penis back down. The fluid goes out of the cylinders back to the reservoir. All right, so that's basically how that works. What is the success of that? Well, highly successful. In men that we select properly, it should work 99, 100% of the time without fail. The problem with penile prostheses is it's an option whereby you can't go back to other things. Once you selected that, you can't go back to needles. You put a needle in one of these cylinders, you basically kill the system. So in a sense, it's irreversible. Commitment is made to move forward with that option. And so patients need to understand that if they go forward with that, that's kind of the decision for life to move forward with that, which is fine, because some men have already explored the other options and they're not for them. In fact, that's what the process of care model is trying to imply here, that you try first line things first, second line things second, third line things third. And that's kind of how we've been thinking about things, at least over the past few decades in general, that a lot of guys that hear about it that way. We know these devices have less than a 1% rate of infection. Again, they're pre-coated with antibiotics. We do these surgeries, I've done more than 2,500 of these over all these years, with great precision. We know how to do these surgeries well. We give intravenous antibiotics at the time of surgery. So these surgeries are done very precisely, very well, in good surgeons' hands who do these surgeries all the time. So they're very successful. But I think the concept is kind of what I'm describing. Each man needs to really understand, is this the right thing for him to do? Now that leads me to where we are now. So this slide here is where we are in our field with the new guidelines. So you heard the process of care model, which is what we had held for about 2 decades, largely with the development of the PDE5 inhibitors in the mid or early 1990s going forward. Now the new theme in our field is to make sure that patients are not held back on knowing what all the options are. Because historically, we used to tell patients, hey, use the pills first. If you don't do well with that, well, think about the vacuum pump or injections. Don't do well with that, we might think about the penile prosthesis. And I think we didn't really accept or understand that some men may have more severe forms of erectile dysfunction, particularly those who've had prior radiation or radical prostatectomy. Those men are not going to respond well to the pills. And we've accepted to move forward here, making sure all things are put on the table, okay, based on understanding the patient's priorities, their preferences, their values with different situations, and maybe the exact clinical profile. Because some men may just feel like, I don't want to use penile injections. Why are we going to force that on that man? Because not everybody's going to be attracted to putting a needle in the penis. In fact, I don't think I've met a man who wants to say he's attracted to that idea. But just the basic thought here is that we want patients to be aware of all their options. And so the new concept here is the shared decision-making model. You see that right on the slide? So you guys are hearing the latest news that is coming out with the latest guidelines of how we, through the American Urological Association, AUA, is trying to make sure people, as clinicians, promote and present what we have to offer. We still have to come up with discoveries that are going to cure erectile dysfunction and fix it. But at least right now, the concept is not just to try to tell everybody that everybody's got to use a PD5 inhibitor. If they have severe ED, probably from long-term diabetes, long-term vascular disease, or even the post-prostatectomy situation where he may not respond well at all. And I'll tell you why in a moment. Here are the real success rates. Okay, again, for a more non-clinical surgeon audience, I don't want to make too many complex slides, but this is just some of the data up here on the different pills we have. So sildenafil is Viagra, tadalafil is Cialis, vardenafil is Levitra, avanafil is Stentra. Okay, I know you've heard these drugs out there. These are the oral pills that I referred to earlier. In the setting of radical prostatectomy, the success rates are shown here. They're not head-to-head trials. Each of the companies have done their independent studies, so we don't know which is better than the other, because these all are very similar. I always tell patients, they ask me, what's better? What drug is better? I said, well, Coca-Cola, Pepsi-Cola, RC-Cola. I mean, they're all in the same class, and they work by the same mechanism. We do know that tadalafil has a longer half-life. It's a slightly differently formulated drug, and therefore the body breaks it down a little more slowly. But in terms of the potency of effect and how they work, they're very similar. And therefore, all we can say is, yes, they have some efficacy in the setting of a man who has erectile dysfunction after radical prostatectomy or after radiation. The success rates are not as good as the general population using these drugs, which is around 70% or so. After radical prostatectomy, the true success rates are probably order of 50 to 60%. And if there's concomitant health issues, that may also compromise that person's best response. Why is it that these drugs don't work well in the post-radical prostatectomy setting? And the answer is right at the bottom of the slide. It takes time to recover after the surgery, where the nerves surrounding the prostate do get traumatized with taking the prostate out. The way these drugs work is that they actually augment the erection effect. They do not induce the erection effect. Scientifically, there's a chemical process where the nerves have to work and make the erections come about. If these nerves are traumatized and they don't recover, sometimes for a year to two, responses to these medications early after prostatectomy are not going to be so good. It's after these nerves recover and they actually get back to a normal level of function, releasing chemicals toward the penile area that help the erections occur, and the drug augments that, is how these drugs work. So the truth of the matter is they don't work in all men early. There may be a time to recover their natural function before they'll start to respond to these drugs. That's the science of these drugs. I don't want to get into detail unless you want to hear more about it. But that was my original research like 30 years ago to help bring about the drugs in the first place. So what other factors play roles that us surgeons have a role in? Well, how well do we do the surgery? New techniques for nerve stimulation and mapping the nerves and being able to understand how we do the surgery, seeing where the nerves are coursing around the prostate. I always tell patients, the way that we do these surgeries, as I mean, the surgeries have been so focused for years doing these surgeries well, it's almost like we're taking the outer layer of an onion off and lifting the prostate out. And within these fascial coverings, of the prostate, almost like an onion. We're trying to at least traumatize these layers that can have these nerves that course all around there. There's not like one big cable, like the sciatic nerve or some other big nerve. Really, it's a network of tiny nerves, like spider webbing, mixed with blood vessels that are in these walls of the outer layers of the onion that we've got to dissect away and still take that onion out. That is really the intricacy of this surgery. And these nerves are multiple nerves that run around the whole prostate at the base of the bladder to the root of the penis. That's what we're trying to do surgically. Not a simple thing. Yes, John?
Is it true that so that the surgeon has a better view of the pattern?
Right, so the question is there techniques about nerve stimulation that we could exploit to do these surgeries better? And in fact, that's bullet number 2. And then there have been techniques called CAVR-MAP and Firefly and flare-up and all those kind of things, where they're being studied, but they're not routinely used in the surgery. And we're still trying to figure out really how to use these better. But essentially, these are the techniques that we're working on to do these surgeries better, because even with nerve sparing, that has been characterized since Dr. Walsh described this in the mid-1980s. Nerve sparing doesn't recover erections in all men. Yes, these other factors you saw me say play roles too, but even with perfect nerve sparing operations, I've done these surgeries for many, many years. I know that gentleman. I spared those nerves. I took out that layer, that onion perfectly, and he comes back a year and a half later saying, Dr. Burnett, I still haven't got my erections back. And my penis is flat. Can't nothing than that. And I'm equally disappointed because I know I did him the very best surgery I can do. And he may be still very healthy. Okay, he's done his job, got his health in the best shape possible. And then what that has to do with this is maybe there are different ways that we can still do nerve sparing better. And even though we think that, and even in my series where we've done, I've had my nurses send out questionnaires and follow up with patients. I have about a 70 to 80% erection recovery rate. It's not 100%. Even in patients who are preoperatively potent with nerve sparing technique, that's probably the best you'll see in the country. I've done that many of these surgeries. And so the reality is we still got to do better. We still got to understand where these nerves are, and there may be various techniques like this that we still have to implement. This slide makes that point. Again, for the surgical audience, there's different layers around the prostate. We have to understand these layers. Surgeons who do these surgeries very regularly have an understanding about what layer of the onion needs to be taken off. Why is this so important? Well, because we don't want to compromise cancer control. We don't want to spare the nerves at the expense of leaving maybe locally spreading cancer. We have to make conscientious decisions about where that dissection plane needs to be to make sure we get the prostate out properly for cancer that starts to spread possibly in some men beyond the walls of the prostate. Okay, and make the right decision with preoperative assessments and intraoperative assessments to know how to take that prostate out properly, preserving nerves where appropriate, but not compromising the cancer control. There have been various studies that have been put forward, again a busy slide here, with the idea of penile rehab. All right, how many people like that term? Penile rehab sounds pretty good. Rehab your penis, come in and listen to all that. I'll sign you up for that. But basically there's been the idea of using PDE5 inhibitors after radical prostatectomy with some sort of protocol or strategy, almost like a vitamin that would help get your erections to get better. You can see the bottom line for each of these bullets. Potential benefit, sustained and sufficient benefit unclear, potential benefit, blah, blah, blah. The answer is that when these drugs came out, okay, in the late 1990s, early 1990s, we understood the science of how they augment erections. There were theories about how they might regenerate erection responses. We had not done the studies. A lot of us surgeons were telling patients, oh, take it every day after radical prostatectomy, take it every day after radiation. It may just keep your penis alive and stronger. Well, yeah, these drugs are pretty benign. They're safe by and large. But we've done the studies now. And in the studies where we've had patients taking the drug every day, another arm where the patients are just taking it if they want to try sexual activity here and there. Others who just say, oh, I'll just see what happens with the best surgery done. All these guys got the same nerve-sparing kind of prostatectomy. A year out, what are the results? They're all the same. Except these guys are a little more poor. They're paying out of their pocket for these pills every day. So what do I tell my patients? Well, I'm going to get to that in a moment. But the bottom line here with this is that we have not really been able to affirm that taking PD5 inhibitors daily really helps your recovery. And I want patients to hear the truth about that. Again, you hear me, one of the messages you're hearing from me is set expectations. Counsel people well, make sure they understand what really is the truth about what we're doing. The International Consultation for Sexual Medicine made the point here that the data are conflicting and there's no real basis at this point to suggest that we have a strong recommendation for penile rehab using PD5 inhibitors. And I think that is the truth. You know, the reason why I think that's so important is because, again, you heard me just talking about setting expectations, but I think it's also important for us to really move the field forward properly. If we hoodwink ourselves to thinking we've solved something that's not really solved, we don't continue to investigate the problem and think about how we can do better with it. And that's that's the message I always tell my residents and those who are trying to study in the field. So how do we proceed? What can be offered that really works? How can we meet patient expectations? By the way, there's also been studies done with vacuum pumps, muse, and injections with protocols saying, inject yourself every other day after a round of vasectomy. That's going to rejuvenate your penis. That doesn't work either. And these therapies are largely just temporary, on-demand techniques that improve the erection response on demand. So we still need to figure out how to do better is the reality. So what do I tell patients? This is what do I do? Okay, as a surgeon who does these surgeries, but also one who's very focused on outcomes, functional outcomes of the patients. First, I educate patients and set realistic expectations. I go over them what to expect with their natural function and recovery, that there is going to be some duration of time where you're going to not be dysfunctional, but things should recover if you've got to mess with the nerve sparing. And that has to do with the knowledge of the science of nerve trauma, the reality of that. Even when we dissect these onion layers off, these nerves, not even just directly cut or anything, they just get traumatized. And all those nerves arborizing in those outer onion layers just need time to recover. I also go over patients' independent and individual risk factors. And I also suggest to them in terms of individualizing care that they can take some responsibility to make sure they're as healthy as they can be. I can do the best surgery possible, but if you keep going to McDonald's every day eating fries and smoking 3 packs of cigarettes a day, that's a tall order for me to overcome, no matter how well I do that surgery. And so also try to understand what patients want to do in terms of their goals, motivations. We do have some rehabilitation options. Yes, PD5 inhibitors are there, PDE5I, but you already heard that I tell patients, we don't really know how effective they may be. Maybe they're helpful, certainly they're not harmful, except to your bank account, but maybe, we don't really have a solution there just yet. Statins, anti-cholesterol drugs, have been studied in some trials. They may have some vascular benefit. You heard me say erectile dysfunction is penile vascular disease. There has been some studies that suggest that getting your vascular health better may help your erection response after radical prostatectomy. So there's some science supporting that. I think that needs to be substantiated further, but there is some support for that. Angiotensin receptor blockers, ARBs, they also have been shown in animal studies and maybe some early non-controlled studies in humans that they may actually preserve vascular health and may be a benefit. Erythropoietin, we studied this in my group, and there's some other reports coming out that suggest that this may be a very important growth factor, a nerve growth factor. Erythropoietin actually is a hormone made in the kidneys that has to do with sustaining our blood cell volume. Okay, so that's what this is all about. It's been studied in people who have anemias, people sometimes with chronic cancers, and they lose their blood counts, and they get on these drugs that help their blood counts. Actually, it's been studied here for various other kinds of situations, brain traumas and others, that erythropoietin early on may actually have nerve growth factor benefit. And there are ongoing trials right now trying to study that in the post-radical prostatectomy setting. So very interesting. Coaching and counseling, all right? I'm one of these surgeons who doesn't say, I did your surgery, see ya. No, I want to work with my guys. I have them come back, see me, I sit with them, go over their follow-ups at different times, make sure that they're being coached and counseled and reassured, and work with them with what kind of care they want to have. And if they want to explore some of these the treatments that can provide on-demand effects And while hoping and expecting that the erections may recover somewhere in the year to 2-year window after the radical prostatectomy, let's support those guys and kind of keep them going. Because I want them to still feel like they're in the game, and they may still be able to be functional if that's their goals, if that's what they want to do. We have clinical trials that go on, okay, and then mention that there's even one with Vibrorect, which is one we've done where this is external nerve stimulator device that we hope and we're studying may help nerve regenerate as a technique that may help guys bring back their function. So what are some of my take-home messages? Well, you've heard me talk about PD5 inhibitors, some promise, but not really proof of benefit. There are various non-oral solutions that may be of use to help promote the erectile response on demand, but do they really cure erectile dysfunction? Do they rehab necessarily? Do they bring about natural function automatically with some sort of strategy or protocol for use, for their use? We have not demonstrated that. Be honest about that sort of thing. There are combination therapies that can be used sometimes. I didn't get into that, but that seems sensible. And sometimes a person may respond to taking an oral pill with a vacuum pump. Okay, sometimes we work with combining interventions. Testosterone therapy, for a bigger talk, I would have gotten into how that has to do with, and the testosterone you're aware of is the male hormones, may have to do with sexual libido and sexual interest more than real erection responses, but there is some science that it may optimize the nerves, may help blood vessel function. There's controversy surrounding this topic. I mean, we could have a whole afternoon of talks on testosterone. Their trials, they're looking at it in the post-prostatectomy setting to see whether it may help functional recovery. That's an ongoing story, remains to be written fully at this point. And counseling and education remain vital adjuncts to how we proceed with regard to somatic interventions, which is the treatments that we offer beyond therapy support, the pills, the vacuum pumps, injections, and so forth. So we individualize approaches. We determine by the shared decision-making model in general for ED, but also in an ED after radical prostatectomy. What are their goals and values and priorities of the patient? What do they want us to do? And be supportive of that patient. Encourage and advance new therapies in the future. So it's a combination of sexual counseling, education, and a variety of therapies put on the table. Try to understand what the patient wants and being able to say, here are your options. They may be all options for you depending on what your preferences are. For the future, we're working on all these kinds of things. The reason I put this slide up is, yes, how many of you guys have heard about some of these things like shockwave therapy? You heard about that? Anybody? How about platelet-enriched plasma injections in the penis? Anybody run down to Florida and get some of that already? Okay. Glad a few of you have not done that. Yeah, some of this borders on snake oil, right? I mean, it really worries you. What's going on? The FDA has not approved this. Some of these things, the studies have not been done. The science has not been backed up. I think they're great theories. I think they are worthy of study, and I hope that we study these things better and bring these to the public responsibly. I'm very dismayed when I hear about these clinics saying, hey, come to my clinic. This is not FDA approved, but we'll inject this platelet-enriched plasma in your penis, just write out a check for $2,500 and we'll see what happens. That is really dishonest. I'm not too happy about any of that stuff. So, but I think these kind of things we still have to study, and maybe they will be in the future once we figure out who is the right patient, what is the right intervention, how are these things administered, even those preliminary data that suggest that shock waves may help blood vessels kind of recover and maybe heal, and maybe there's preliminary data about stem cells and platelet-enriched plasma that may rejuvenate some tissues. But we got to figure out really what is the real science there, what are the optimal patients and the optimal conditions. We need to do a better job, I think, from a medical community to do that and bring that forward. So, stop showing off. I know it's a walking stick. I'll throw a little hilarious slide in somewhere. All right, so I'm going to stop there, and I hope I've been able to share with you my thoughts about the issues surrounding functional recovery. I welcome some questions. Yes?
Hi, so Dr. Burnett, that is a barrier for my patients who can't afford any of those treatments.
All right, so the question, as I understand it, and make sure everyone's hearing it, is what about the financial aspect of managing ED? There is certainly that aspect of expense, And with therapies that are out there, can all men be available to these options based on limitations here of cost, which I think is a very important and certainly practical matter here that we need to put into the discussion. And where does that stand? And the answer is that this is a challenging area. Believe me, I've gone to the Hill, Capitol Hill, and fought on behalf of my patients with various kinds of consensus groups to try and change bills, to try to figure out ways that we can create support for patients. You know, as you know, there's been support for women with breast cancer, and almost unbelievably, the same kind of support is not there for prostate cancer. Okay, maybe women do a better job of galvanizing, getting down to the Hill en masse, and almost breaking down the senator's doors to make sure something happens. That's, you know, you heard earlier today, you know, us fellas, well, we don't care about that. I just want to get to the garage and fix my car. So part of it has to do with just, you know, this squeaky wheel gets the grease, and we need to do a better job to advocate. The AUA is doing really as best they can with advocacy. We go down to the Hill almost every year, multiple times, with various strategies and efforts. Where does it stand? Well, it stands with, I think, if the government can establish through Medicare what they will pay for, maybe third-party payers and insurance companies will follow suit. Right now, they've withdrawn support for vacuum erection device therapy. That's gone. PDE5 inhibitors largely are not paid for. Penile prostheses are paid for. Hope that doesn't disappear. Or that may in the future, who knows? But I think we need to continue to advocate and show that there is some importance to restoring a man's wholeness, and that these are very important aspects of a person's health. It can be argued that the penis is a little bit more functional than a breast, but I'm not going to take anything from women. But the reality is, you know, for a couple, having those kind of relations really does require at least that function of working to some extent. So it's almost amazing that we don't have this. But we're fighting, and we're doing the best we can do. But this is where things stand, and unfortunately, yes, some patients are kind of out in the cold here. We continue to try and fight on behalf of some third-party payers. I write appeals letters all the time for my patients for various situations, and I think we got to try and do that as best we can, because we know sometimes the third-party payers are looking for the easiest way to say, deny, you know, that sort of thing. But that's where things stand, and we just got to keep